I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, everyone, and welcome to the March edition of the PRS Journal Club podcast. My name is Sammy Sinno, a resident from NYU, and I'm joined by my co-resident ambassadors, Amanda Silva from University of Chicago and Raj Sawh-Martinez from Yale. We are very fortunate tonight to be joined by ASPS President Dr. David Song, who's the chair of the plastic surgery program at University of Chicago. Dr. Song, thanks for joining us.
Oh, thanks for having me. This is fun.
Thank you. So the article that we're going to discuss next is a randomized clinical trial to evaluate the safety and efficacy of lidocaine-containing monophasic hyaluronic acid filler for nasolabial folds. This is a study from Korea by a group of dermatologists. Obviously, the use of hyaluronic acid fillers is one of the most commonly performed procedures in all of plastic surgery. And this is a randomized, multi-centered, double-blinded study that looked at the difference between a new monophasic hyaluronic acid filler called Noramis Deep Lidocaine, comparing that to Restylane Perlane, which is a lidocaine-containing biphasic hyaluronic acid filler. What they did was take 60 patients and applied all of their inclusion criteria to get to these 60 patients, and eventually had 58 that completed the study. In one nasolabial fold, they had the new monophasic filler injected, and in the other nasolabial fold, they had the standard biphasic hyaluronic acid filler. They then had each of these patients evaluated by blinded investigators at 8, 16, and 24 weeks after the injection, and they were graded on the wrinkle severity rating scale and the global aesthetic improvement scale. What they found was that the new monophasic filler actually had better scores, statistically significant better scores from baseline at 24 weeks in terms of wrinkle improvement and overall global aesthetic improvement. They also wanted to evaluate the safety of these two different fillers in comparison, and found that there was no difference in pain between the two fillers as they both contain lidocaine. The authors then postulated why might the monophasic filler have better overall outcomes, and they had some interesting conclusions. Well, when they actually formulate these monophasic fillers, they actually have a more homogeneous distribution within the dermis, and this allows these type of monophasic fillers to fill even the smallest spaces between the collagen fibrils. In addition, they say that biphasic fillers typically form larger aggregates, so there may not be as smooth of an effect, and they show this in clinical photos. Additionally, this new filler is formulated using what they call shape technology, which is a special cross-linking strategy for allowing this particular filler to remain primarily cross-linked for a longer period of time, so they undergo much slower degeneration by the body's hyaluronidase. This particular filler also has a larger needle, so some would think that this would actually increase the pain on injection, but this is a special design needle that allows laminar flow, and in theory this would reduce the pain of injection so that it's found to be negligible when compared to the standard. Now, the reason I think this article is very well done. I think whenever I see a level 1 or 2 study in the journal, my eyes light up. I think that's what our field needs more of, and not just aesthetics or cosmetics section, but really all the subspecialties of plastic surgery. And if you go and read the preparation and execution of the planning of this study in this article, you have to appreciate how well done it is. I think you cannot argue with the results that they've obtained that are of statistical significance, because they've really carried out the highest level of study possible, level 1. And I know in currently trying to do a level 2 study, how much work goes into just the planning and how much scrutiny undergoes the study in terms of the IRB. So I guess my question to you, Dr. Song, is, one, what do you think about the article? And secondarily, how do you think we can get more studies of this type, not just looking at fillers, but sort of in all the subspecialties in our field, to try to increase the overall level of evidence of our literature.
Yeah, Sammy, thank you. I read this article with great enthusiasm because of what you exactly mentioned. I mean, double-blinded, prospective, randomized trial. I mean, that's in our journals. It's a rare bird. Now, having said that, I think this could only be done in places like Korea because you're using a patient for her or his own control. You're injecting one product into one side and another product into another side, and boy, what happens at the end when there's asymmetry, as has been pointed out by independent examiners?
Right.
It's unclear to me what the investigators did to help mitigate that in the long run.
Right.
2 years later, one side looks different than the other because of different products. There's asymmetry. Are they going to offer the patient some amelioration of that? And that was unclear in the article. So any type of situation where you're using a patient as his or her own control and applying two different therapies, that would be really difficult to pass muster in any IRB that I know of here in the States, because of exactly what I mentioned. So it is fascinating.
Well, maybe it'd be tough in New York or Chicago, but New Haven, Connecticut, they could probably pull that off.
Exactly.
You can do anything in New Haven.
Yeah, right. Yeah, in most of the first world cities like Chicago and New York, it would be definitely raise some eyebrows, and I don't mean from the aesthetic sense. It clearly is going to be something that an IRB would probably not allow to happen. Having said that, I was excited to see what type of novel findings that they would discover, and basically what they found was that the monophasic was slightly better than the biphasic, and I don't know if that was their goal, and it clearly wasn't to show superiority. If I read it correctly, it was to show safety and efficacy equivalence and not superiority. So that's kind of interesting to see. So my comments on these type of randomized double-blind controlled studies, yes, we definitely need to do more. But, in certain things that we do in surgery, because so much of the emphasis is on craft and experience, that we shouldn't discount that as well. There was never a double-blinded randomized prospective trial for parachutes, right? So, you can't, there's certain things that we do in surgery that don't necessarily need, a prospective randomized double-blind trial. But things like this definitely can benefit from, therapies that are commoditized therapies can definitely benefit from superiority and efficacy studies. So it was fascinating to read how they did this. The other thing that I'll comment on is that, Asian and particularly Korean skin is going to be different than African American skin, than Hispanic, Latino skin, than Caucasian skin. So, we have to take a lot of this with relevance and to the Asian aesthetic, as opposed to perhaps the finer wrinkles that we see in Caucasian skin. The dermal thickness is different, aging is different, as you know. So this is an important study, in my opinion, for the Asian population, but it's not going to necessarily translate well to other ethnicities.
Why is it that it seems to me as a resident that the aesthetic surgery in Korea seems to be so far ahead of the game? I mean, there are some procedures like malar reduction and malar augmentations, mandibular reduction, procedures that really you don't even hear or really see discussed in the plastic surgery literature in the States, but there's so many experts in certain aesthetic procedures in Korea. I know you were recently there. I know you're Korean. What allows that? Is that maybe a little bit of what you alluded to, the ability to have the freedom as a surgeon to not experiment, but be a little bit more creative with techniques, or is it just the culture that demands a higher level of aesthetic surgery? What? At least that's my perception. What's your opinion on that?
Yeah, I mean, your perception is spot on. I think that, having traveled around this year and in the recent past, I say this, obviously I'm trying not to be biased, but when I've seen this in Seoul, I mean, aesthetic surgery, particularly facial aesthetics, is really leaps and bounds above anything that I've seen before. I think there are several reasons why that's happening. You have a homogeneous population. So standardization of therapy can be quickly adapted, as opposed to, in New York or Chicago, your aesthetic patients, in the morning could be, 60% Caucasian and, 20% Latino, 10%, African American, and so forth. Well, in Korea, they're virtually 100% Asian. So you're having that sense of homogeneity. So you're able to really get good at certain things. Secondly, I think the culture in Korea places a premium on appearance and the ability to look your personal best. There's sayings like that, and it's embedded in the culture. And so I think you combine that with the expertise and the experience of the surgeons that really strive for pushing the envelope in aesthetic surgery and aesthetic medicine in general, and you're starting to see these type of studies and sort of the epicenter of innovation of aesthetic surgery, particularly in the Asian face, happen in Seoul.
Interesting. Sammy and Raj, I'd be curious. So here at UFC, some of the aesthetic surgeons we work with don't really fill the nasolabial folds anymore. They use a product, Voluma, and they'll fill the malar region to kind of lift the face, and they say that helps with the nasolabial folds. Is that something you guys have seen as residents in your cosmetic rotations, or?
I've seen both. I think, for me, I always think it's very dangerous. I think not every nasolabial fold is equal. I think there's young patients that think they have deep creases, but it's really, I think, in contrast with the volume of their cheek naturally, and you can create a really unnatural appearance with fillers. And my attendings have taught me certain techniques to, fill closer to the alar base, to lift a certain area superiorly to, mask some of what may be displeasing to them. But I think it's to me, I think is a very, I was taught a very cautious injection in terms of using your own personal aesthetic to create what the patient will see as a perceived improvement. I have seen Voluma used sort of to mitigate that. I don't know, Raj, have you seen anything else?
Yeah, I think you're sort of alluding to the point. We're sort of the surgeons that we've seen sort of use it, really tailor it to what the patient's needs are. So if someone is deficient in that malar area and has deep nasolabial folds, then I think they'll see the impact of a filler in that area, in the malar region, augment that and see what that effect that has first in the nasolabial fold. If that corrects it to a sufficient amount, then they'll probably bypass it. But some patients, have great sort of cheekbones and have enough sort of seeming volume in that area. So then they're just complaining about a sort of a minor amount of pressure in the nasolabial fold. And so, they'll still inject it. And just like Sammy was saying, with all the different precautions and, knowing when to, inject as you're drawing out and ensuring that you're pulling back so as to not get into a blood vessel, that kind of thing. So, I think with caution, that actually has a really nice effect. We have our resident cosmetic service, and we'll do filler workshops, and we really go through some of those details to really tailor it specifically to what the patient would need. But I can say that there's been a trend to completely get away from it. We still do both, but will vary how much and where and how frequently, depending on what the specific needs of the patient would be.
Mm-hmm.
What's interesting that I just want to make one comment on fillers in general. I think that we have to be better as a specialty about utilizing fillers in animation. A lot of the great results, and even in this example, you see them in repose. And so, and you're not seeing them in animation. Sometimes they look amazing in repose where they're just, a snapshot, and you start to talk to a patient and realize, oh my goodness, this patient has had way too much voluma or way too much whatever, and the animation is very unnatural. And so I think that's the next challenge for the younger folks, to figure out how to provide fillers, whether it's product or fat, to do it in a way where it looks great and natural, both in repose and on animation. And, I would love to see more articles in PRS Go and PRS that show long-term results, and rather medium to long-term results with fillers and fat with patients in animation, perhaps movies, because that's really the true mark of great aesthetic delivery is when patients look great in repose and also look natural and great when they're animating. And we all have seen it where a patient comes in the clinic and, you walk in the room and the minute they smile, you're like, whoa, what happened here? and as soon as they're in repose, it looks great. And so once again, a lot of the pictures that we see in our journals are static pictures in repose and they look awesome. What happens when they smile? That's the real question.
Mm-hmm.
Yeah, great. And we'll probably leave it there and move on. Sorry, go ahead, Sammy.
No, I think that was a great discussion on a very well done study from Korea. Thank you, Dr. Sawh.
Yeah, thank you.